Hi, this is our case 6 presentation. Our case is an 85-year-old man and he's very friendly. He lives in the facility and everyone likes him. His family is far away, so he doesn't have many visitors. He has fallen several times before, and now he's in a wheelchair 100% of the time. In the past month, he has become less talking and participating. A staff member noticed that he was quiet and withdrawn, and also he has fallen twice recently, so the staff member referred him. He's 85 years old and he drinks about 20 ounces of water and 4 cups of coffee a day, and he has moderate pain and moderate to severe fatigue. Also, his voice is weak, and he has voice problem in the past 6 months, and he also have mild hearing loss. He doesn't have any medications and swallowing issues. His total scores of voice handicap index are 40. It means he has mild to moderate voice-related handicap. These are the scores of evaluation of voice, and he has the mild to moderate breathiness and loudness, and also all the values are consistent, and it consistent with client perception and hypofunctional hypothesis. These are the data of acoustic. The result of perturbation is above normal limit, and also Mr. GP has lower mean intensity and max intensity compared to the normative value for older men. These are the data are about aerodynamic. Mr. GP has lower values in sound pressure level, subglottal pressure, laryngeal airway resistance, phonation threshold pressure, and maximum phonation time compared to the normative values. And also, Mr. GP has higher values in mean airflow compared to the normative values, and these are consistent with client perception and hypofunctional hypothesis. The electroglottogram shows that Mr. GP has small close ratio and short close time.
As for our stroboscopy, we found the results were consistent with hypofunction. This was evident in the vocal fold edge being concave, which is shown in the image to the right, spindle gap during adduction, and also a predominant open phase. We also saw more elasticity in the mucosal wave and a larger amplitude. Since our client was not getting full vocal fold closure, we decided to do a laryngeal EMG to ensure there wasn't any neuromotor functional issues. And our results came back normal, so that means our superior laryngeal nerve was functioning properly and innervating the cricothyroid and posterior cricoarytenoid muscles. So to summarize our assessment and review our clinical impressions, we have a client who's an 85-year-old man presenting with mild to moderate dysphonia. The main symptoms being a breathy voice with low volume and resulting in vocal fatigue. We noticed the breathiness came from a high airflow rate and low subglottal pressure, resulting in a decreased laryngeal airway resistance. We also noted some roughness and strain during the acoustic perceptual assessment, which was evident when we saw slack in the mucosa on the stroboscopy. Moving on to diagnosis, we were between two options, presbylaryngis and Psoas vocalis. The support for presbylaryngis included the symptoms, breathiness, reduced volume, and vocal fatigue. We also saw in imaging the vocal fold bowing due to muscle atrophy and shrinkage, and for our client we saw that concave shape to the vocal fold edge. In addition, we had insufficient glottal closure and a spindle gap. And we didn't see any incongruence between our assessment information and the available evidence supporting presbylaryngis. We had similar support for the sulcus vocalis, including the symptoms, the concave medial edge of the vocal fold, the loss of tissue, and just a cause of aging. However, there was also some incongruence. Our client did not display any compensatory behaviors. We didn't see any asymmetrical vibration patterns or different vertical vocal fold levels. And there's also a number of causes that could be a result of sulcus vocalis that did not apply to our client. After comparing both options, we decided with the diagnosis presbylaryngis. Both diagnoses supported the symptoms we were seeing in our client. However, the sulcus vocalis we thought was less likely because our client was only presenting with a select number of those symptoms, whereas the client presented with almost all the symptoms involved with presbylaryngis. We also didn't observe a sulcus on the stroboscopy. For our intervention, we wanted to focus on those chief complaints. We were looking to lower vocal fatigue, increase volume to 70 decibels, and increase max phonation time. For our first goal, we're working on decreasing vocal fatigue, and we're going to measure this by using a scale of 1 to 10, 1 being no fatigue, 10 being high fatigue. And we would like our client to report lower than 3 on the fatigue scale by the end of therapy. So the succession we're going to be using is beginning with 6 or lower, and then moving the goal to 4 or lower, and finally reaching 3 or lower. For our second goal, we would like our client to maintain at least 70 decibels during short conversation, and we're going to move up in increments starting at the word level to the sentence level. For our third and final goal, we're looking for our client to increase their max phonation time. In their assessment, their max phonation time was 16.32, so we're slowly moving them up in increments to 20.03, which is the lower range of the normative data.
So here are our 3 intervention options that we're going to be using with our client. So we have forte exercises, effort closure, and vocal function exercises. Forte exercises will be used for our goals of increasing our client's decibel level, as well as increasing his maximum phonation time. Effort closure will be used to address our goals because increasing that effort in different muscle groups can help increase effort at the level of the vocal folds, therefore increasing subglottal pressure and intensity. And then for vocal function exercises, the goal for those will be to strengthen our client's laryngeal musculature and improve his overall efficiency of his airflow and vocal fold vibration. So goals of our second and third steps of vocal function exercises will be for the client to have no breathiness, whereas steps 1 and 4 of vocal function exercises will be aimed at increasing our client's sustained soft phonation time. One intervention that we don't recommend using with our client is the Yon-Sai technique. We think that this might counteract the benefits of our effort closure technique. And potentially, Yon-Sai could be used with our client at a later time if he does mention feeling any tension, but as of right now, it's not recommended for him. So this is our protocol for week 1 with our client. You can see we're doing our 3 short-term goals. Those are going to be addressed with our client. For our first short-term goal, we're doing effort closure exercises, and we're going to do those 2 steps with our client. So he'll practice the exercises by squeezing his hands together, as well as practicing effort closure techniques at the word level. For our second short-term goal, we are going to be doing forte exercises. So he's going to do the first 2 exercises for forte. So that's sustaining the sound ah in a strong, energized voice as long as he can, and also doing pitch glides on ah, going from low to high and also from high to low. For our third short-term goal, we're going to be doing vocal function exercises with our client, and he will work on those 4 exercises we have listed out as a part of those. Additionally, in week 1, we are going to be asking our client self-efficacy questions, such as, what do you like about your voice? If you could change anything about your voice, what would it be? As well as giving him some encouragement as a way to just get to know him a little more and form that client-clinician relationship. For weeks 2 to 5, we are going to continue with our 3 short-term goals. Our first and third short-term goal exercises will look the same, but for our second short-term goal with the forte exercises, we will be adding the third exercise of producing self-generated functional phrases. Also, for weeks 2 to 5, our homework for our client will be to practice those forte exercises at home, following along with a video that walks him through the functional phrases. And our client will also be provided with a list of 10 words so he can practice effort closure and practice phonating through a straw. In week 10 with our client, again, we're continuing those 3 exercises, those 3 short-term goals. And for short-term goal 2, we're adding on that 4th exercise of conversing in a strong, energized voice as if our client is in a noisy restaurant. For maintenance and homework for week 10, our client will practice his effort closure exercises, he will remember to think loud with his forte exercises, and he will practice vocal function exercises while phonating through a straw. And here we have our loudness goal for our client. You can see how at the baseline he started with an intensity of 61 decibels, and at the final session he ended with an intensity of 75 decibels.
On this slide, you can see the data for the maximum phonation time goal, and you can see that GP's maximum phonation time increased over the course of the semester. He started at 16.32, and then he ended at 20.1 seconds. This slide shows the data for the vocal fatigue goal, and you can see that GP's fatigue rating also decreased over the course of the semester. He started at a fatigue rating of 7, and he ended at 3. This chart shows the KV results from both before treatment and after treatment for GP, and you can see that there's a trend in all of the scores reducing from pre-treatment to post-treatment. We also know that GP is ready for discharge because the goals that he worked on in therapy are generalized and maintained now. He's reaching within normal limits for many measures, and his patient-reported outcomes have improved as well. This chart shows the results of the acoustic measures both pre-treatment and post-treatment, and you can see that several of the measures that were either above normal limits or below normal limits before are now within normal limits. And you can see this in measures such as max intensity, mean intensity, and perturbations. This chart shows the results of the aerodynamic measures both before and after treatment, and similar to the acoustic measures, you can see that there's a trend that the scores that were below or above normal limits before treatment are now within normal limits after treatment, and you can see this, for example, in results such as the change in subglottic pressure and maximum phonation time. These images show the results of stroboscopy both before treatment and after, and you can see that there's a spindle gap in GP's vocal folds before treatment, and then after treatment there isn't a gap anymore, and his vocal folds appear normal. Following treatment, GP reports that his voice doesn't feel as effortful anymore. He reports that people can hear him a lot better now when he talks, and he feels like his voice is a lot less breathy, it's louder, and his speech is a lot clearer, which is exciting for him because now he can go back to playing bingo, which is something he really loves to do. Also, his results on the voice handicap index were significantly decreased from a score of 80 before treatment to a score of 20 after treatment. GP is an 85-year-old man who received a medical diagnosis of presbylaryngitis. He presented with mild to moderate dysphonia before treatment because of glottal insufficiency, as well as a slightly low intensity level. He also reported fatigue as well as moderate impairment as a result of the effort that it took for him to produce a voice that was both quiet and breathy. In terms of treatment, GP did phonation resistance training exercises, effort closure, and vocal function exercises for 10 weeks of intervention. After treatment, his glottal insufficiency was resolved, his voice is a lot louder, and he reported less fatigue as well as less breathiness. Now he reported that impairment has decreased and he's a lot more satisfied with his voice. GP's prognosis for maintaining the gains that he made in therapy is good because he's really motivated and he is eager to complete the homework exercises that he's assigned on his own time. Also, the staff at the nursing home that he works with is really supportive and they help him to practice when he needs help. We recommend that GP continues to practice good vocal hygiene and also to keep practicing the therapy exercises that he learned in his sessions on his own time, such as the vocal function exercises and the effort closure techniques. We want him to contact the clinic if he has any questions or concerns in the future, and it was great working with him.